A very warm welcome to this, in my eyes, very interesting session. So in the past decades, imaging has evolved from a supporting role into the true driver of our daily structural heart interventions. So this topic will be about the advancing structural heart with 3D intracardiac echo and device guidance. So what are the objectives of the session? So we would like to understand how 3D eyes can add value, and both alongside and independently of 3D TE. We want to recognize imaging strategy that supports procedural precision, and especially in terms of leaflet grasping, trajectory alignment, and device positioning, because these affect the safety and efficiency of our procedures. We also want to learn workflow models that improve the efficiency and communication and the team performance, and we would like to identify practical steps to adopt standardized imaging protocols, including for LAA closure and tricuspid edge-to-edge repair. So this is just to remind us that globally, if you look globally, we have fewer than 3% of global structural heart proceduralists that are female. And we also have to keep in mind that fewer than 1.5% of authors in structural heart trials are female. So that's why it is immediately a really great pleasure to introduce to you a pure female panel. So we have a link from the UK. We have Miriam Wild from Bad Kreuznach in Germany. We have Victoria Delgado from Spain, and we have Becky Hahn from the US, a really expert panel. So Victoria, you're the next to give us an overview of the upcoming imaging modalities we can use in the future.
So thank you very much, Nina, for the introduction, and thank you very much to the audience for joining us in this live case that we will see later on. But to start with, we are going to see the innovations in technology relative to imaging, and particularly I think that one of the most advances had occurred together with the advent of the transcatheter interventions. These are my disclosures, and I like to use this old slide just to clarify, to illustrate this journey that we have done together with the transcatheter interventions. With the surgery, we see directly the structure that is going to be replaced or repaired, but with transcatheter interventions, with the fluoroscopy, we don't see the soft resolution that 3D imaging is providing in order to really see which is the structure that we are going to treat and where we are going to go with the devices. So this is a key element of the transcatheter interventions of the cath lab. And we can deliver that 3D imaging in a different ways. We try to minimize the devices that we use for imaging as much as we can in order to be less traumatic, in order to be more efficient, in order to have less dependence, for example, from anesthesia. And so far, up to now, we have, for example, the intracardiac echo, which would be 2D or 3D. And even the transesophageal echo, we have miniaturized probes that can provide also a 3D image quality that is almost as good, if not even the same as good, as the regular transesophageal probe. These mini transesophageal echocardiogram probes do not need for general anesthesia if you don't want, and the problems that they may have is the shadowing from the neighbor structures that you don't have with intracardiac echo, and the limitations that the mini TOE probe has are due to the far-field ultrasound physics that you will not have with intracardiac echo. So both systems can provide you a superb image quality with 3D, and it's a matter of knowing which is the structure that we are going to treat, which are the challenges that you may face, and choose the right tool for the right target. This is just a slide to summarize the evolution that we have seen from imaging, particularly on echocardiography, and we are not going to go as back as when it was developed with the N mode, but you can see that we have tended in the last 30 years going more to 3D image. Why? Because we need that 3D image. We don't need only the 2D because we have only one plane. Our structure, the heart, is a 3D structure, and therefore we need this 3D imaging. And these are the probes that we have at the moment if we are using a transesophageal echo, and I just put side by side what you get from a normal transesophageal echocardiographic probe versus the miniaturized transesophageal echocardiographic probe. You can see almost the same quality with the same features in order to even see the cast of a structure such as the left atrial appendage, so that we can define which is the morphology. We don't need the CT to evaluate that morphology, and we can have the images with the multiplanar reformation planes later on to get the measurements for deciding the size of the device that we are going to implant. And this has been studied, for example, if we use a mini TOE for a left atrial appendage closure, one of the most frequent procedures to perform, that actually the mini TOE has the same accuracy and the normal TOE that you need to use anesthesia, general anesthesia, while with the mini TOE you don't need this anesthesia, you need just a light sedation, and you can have the procedure with the same technical success that with the other one. And in addition, you can also have the technology together with fluoroscopy in order to have the fusion imaging with this mini TOE, so that you don't lose that communication at all between the interventionalist and the imager. You have everything on your screen that you need in order to perform the procedure. We have as well now the possibility to perform 3D echocardiography with intracardiac echo, and this is, for example, one of the devices that we have now, the VeriSight Pro Eye system. And here you can have a direct visualization of the structure that you want to target. In this field, the intracardiac echocardiography, you have you can use it as a standalone, for example, for a transeptal puncture, for a PFO closure, for pulmonic interventions, or ASD closure and left atrial appendage closure, and is an important adjunct to use, for example, for mitral interventions or for tricuspid interventions. The issues that we have, particularly in Europe and, for example, in my country, will be reimbursement. But in principle, is a good tool to have when you face difficulties with transesophageal echocardiography for some procedures. So here there is kind of summary slide, the comparison between 3D eyes and 3D mini TOE probe, which would be the one that could eliminate the anesthesiologist from the room in order to have perhaps more procedures to do. And actually, in principle, these differences rely on the cost of the catheters, on the image quality compared to the standard reference that we have, and also the learning curve and who will be doing that echocardiogram if we want to use the eyes, because this is a very important field in order to align and to design the cath labs of the future so that everybody can work together with a perfect communication. Thank you very much for your attention.
Thank you very much, Victoria. So we'll have a discussion more at the end of the session, because we'll see the application of 3D intracardiac echo and the DeviceGuide during a real procedure, a live procedure. So Becky, go ahead. So you have a new interesting imaging technology to demonstrate.
Yes, this is, we'll review DeviceGuide in just 6 minutes, so it's a little bit of an abbreviated presentation. But the classic fusion imaging, which you already saw, fuses the echocardiographic or CT imaging onto the fluoroscopic screen. But often this is really misunderstood by the interventionalists. It's not what they need. We actually are the ones that probably need the fusion on the imaging side. So what DeviceGuide does is it recognizes the probe and recognizes the device, in this case the ACE device, Pascal ACE, and is then able to configure the three-dimensional multiplanar reconstructed image as long as the volume of the TEE probe and the device itself are adequately married. So you need to have the device within the volume, and then it can reconstruct. And so this is just a new way of co-registering the images, allowing us to use AI to recognize the probe and recognize the device. There are 3 different modes of the DeviceGuide. The default mode allows you to determine the actual target, and this is done by the imager. And once you've defined the target, then that target will remain embedded into the DeviceGuide program when we go to target mode. The device mode itself allows us to maintain our image of the device at all times. So you can really see, and we'll show you in a couple of subsequent images, that despite the fact that I'm moving the probe in order to get away from the shadowing, the acoustic shadowing of the guide, that we're able to maintain the image of the device at all times and therefore ensure not only safety of the device but also the accuracy of device placement. And then finally, the target mode allows us to have overlays, and the overlays involve both the fluoroscopic image and the echo image, allowing us to see, which we'll see in the next slide, a number of different features that allow us to be more precise. And those features are that it can show us from the fluoroscopic image the trajectory of the device, and that's the yellow dotted line. So that's been placed not only on the fluoroscopic image, but also on the echocardiographic image. And therefore, we're always able to image whether or not we're on or off axis to the plane of the annulus. The blue icon allows us to see the device itself and whether or not we're in plane or out of plane. In plane means that we'll have a darker device, and out of plane, a more shadowed device, a fainter device, and therefore allowing the interventionalists to get an idea of how close they are to the target. And then the yellow box replacing the short axis view continuously images the device. And so when we're looking at for instance, in this case, device mode, as I showed you before, small motions of the probe or respirphasic variability is really, we can maintain the imaging within the yellow plane at all times, which will help us significantly when we're doing procedures. So you can see the respirphasic and the RR cardiac motion in the white boxes of both the 3D and the fluoroscopic image, but the yellow image maintains the same image of the device at all times. And once we can ensure that the device is along our targeted planes, so the red plane and the yellow plane are the same, then we can go ahead and understand that the interventionalist has hit the target with the device. Now we're going to show you in just 2 minutes and 28 seconds the performance of a complex TEER device with the ACE, Pascal ACE, in this example of an A3P3 prolapse. So this is a complex medial prolapse of the two leaflets, a very complex jet, which you can see from the AP view is splitting the jet, and obviously with a significant amount of regurgitation. And so in 2 minutes and 28 seconds, we can show you that we've positioned the device above the leaflets, and then we can advance the device knowing exactly where we are at all times with the blue icon on the short axis en face view, rendered view. And once below the leaflets, we don't need to drop gains or change views in order to see where we are. DeviceGuide allows us to know exactly where the device is, and you can see the device now open below the leaflet tips. So again, on the en face view, you can see the blue icon, and it is quite dense because they're very close to the target. Once we're very close to the target, we want to be sure that our trajectory is perfect. And you can see that the trajectory lines are now aligned with our red line on the green plane and the green line on the red plane, and therefore the trajectory is perfect for grasping. Now, you can see from the yellow plane that is now enlarged that this very complex-looking prolapse, which again is both the anterior and the posterior leaflets, are in view with the device at all times, despite respirphasic and RR variability. We're able to then grasp the leaflets and make sure that we have enough leaflet within the clasps. So we'll be dropping again now. And then once we've dropped the clasps, we can close and either use DeviceGuide on color or turn off the color. At any time, you can turn off DeviceGuide whenever you want in order to ensure that you have the best temporal spatial resolution throughout the procedure. But this is a 2 minute and 28 second continuous video clip of this entire procedure, which we were able to perform and obtain an adequate result with just one device in a complex anatomy. So this is the final A3P3 prolapse. On the top, the baseline imaging. On the bottom, the final 3D imaging. Single device, bringing the what really was torrential mitral regurgitation down to trivial. And this is, again, with DeviceGuide. We do believe that this device is important for efficient communication and streamlining procedures, allowing us to have less inter-operator variability and expanding the device therapy to different levels of operator experience. And we really want to thank our collaborators, Philips Healthcare and Edwards Life Science, for allowing us to participate in the SMART-VIEW trial. Thanks for your attention.
Thank you so much, Becky. I think we got some insights and some very new and interesting imaging modalities, and we have the chance to see some of these imaging modalities applied in a live case today. And Victoria, you will introduce the patient to us, and then we hope we can get a connection to Bad Oeynhausen, where we can see all the technologies live in the cath lab.
Thank you, Nina. It will be my pleasure to introduce the case that the group of Bad Oeynhausen, Germany, will be presenting. This is an 81-year-old female that presents with progressive heart failure symptoms and worsening of exertional dyspnea and leg edema. And she is diagnosed with massive tricuspid regurgitation and right ventricular dilatation, and she is referred for tricuspid regurgitation evaluation. So she has a heart failure with preserved ejection fraction, didn't have coronary artery disease, has known paroxysmal atrial fibrillation and history of ischemic stroke in 2018, and also has a chronic lymphocytic leukemia. As a cardiovascular risk factor, she has arterial hypertension, dyslipidemia, and stroke. The clinical presentation, she is with frail with a low weight, and she's independent for living. This is the medication that she's taking, so actually she gets the 4 pillars for heart failure medication, and these are the results of the lab test with a very high NT-proBNP, a renal function slightly reduced, and a bilirubin that is normal. The patient underwent for a right heart catheter, and here you have the values with a right arterial pressure mean of 5, with a big wave of 16 millimeters of mercury, an end diastolic pressure of the right ventricle of 7, a pulmonary arterial mean arterial pressure of 17, so ruling out the pulmonary hypertension, and a wedge pressure of 12. This is a transthoracic echocardiography where you can see that the right ventricle and the right atrium is dilated. There is not much tethering of the leaflet, so that is more into the direction of an atrial tricuspid regurgitation. The TAPSE of the ventricle is 17, so it's not very much reduced as the cutoff values of current guidelines have provided, and the global longitudinal strain is a little bit more reduced compared to the TAPSE. These measurements also lead us to perform much more 3D echocardiography, which provides also a volumetric assessment of the right ventricular ejection fraction, which is 41%, so in the reduced level. And this is the tricuspid regurgitation with the vena contracta area of 0.92, with a vena contracta onto the of 11 and a regurgitant volume of 51. This is the transesophageal echocardiography images, the ones that you will use at the mesoesophageal at the level of the aortic valve to sweep the from anterior to posterior the tricuspid valve leaflet and seeing what is the measurement of the gap. And here you can see the regurgitation, which is very central. And this is the transgastric with an acceptable quality, where you can see that the regurgitation is from the center and more towards the posterior septal commissure. So based on this analysis, if we apply the GLIDE score, which is 3, you can see that is already going in a direction that is going to be challenging, but the most important thing is that the images, particularly the transgastric, which is very important, is challenging, and perhaps we can have ICE catheter there for better evaluation. So based on the high comorbidity burden and the frailty, the heart team decision was performing a transcatheter edge-to-edge repair guided by 3D ICE. So this is the presentation.
Yeah, thank you very much, Victoria, and I hope we can get a connection to Bad Oeynhausen and Tanja Rudolph and Kai Friedrichs, who are performing the case today.
Good evening to London. Welcome in the hybrid OR in Bad Oeynhausen. To my right-hand side, Kai Friedrichs. We have also in the room as an imaging specialist, Maria Ivanikova, and we are also accompanied by our anesthesiologist, Natalia Efimenko. And you heard already the presentation of our patient. And first of all, we would like to talk a little bit about the strategy we are planning here. So from what we have seen from the TOE and the screening, we plan on a one-clip strategy here, might be sufficient. You can now see live. And
maybe we can show the echo.
Yeah.
There we are.
So you see it's a 3 leaflet anatomy, a rather long posterior and septal anterior and septal leaflet. The posterior leaflet is rather small. The predominant jet was coming from the posterior area of the valve, and we have already in place Pascal ACE device, already orientated what we think might be the best way to treat the TR in this patient. Well, we'll see if one clip will be sufficient to reduce it. What is important, what we would like to point out is that all our patients before undergoing TEER undergo prehab, so diuretic therapy, and the patient is in the hospital since Friday and underwent intensive diuretic treatment. So do you have any comments so far from London?
No, I think the images we've just seen are TE images, and you will focus a little bit on the imaging you will use during the procedure. Becky, some comments from your side?
Well, I was just, you'd pointed out on the echo, at least, that we saw that there might be a little bit more posterior. But I think it looks as though you've positioned the device at the very center, but on the anterior side, which I like, because I think if you're going to do a one device therapy, that's pretty much where I'd put it. But are you concerned at all that you won't address the posterior jet?
That's a good question. I think we might consider to have a second device as backup. The reason why we choose this position is that we also want to avoid the AP commissure. The AP commissure is not very pronounced, not very big, but it's a try, maybe to address everything with this one device, one clip strategy. If there will be a residual jet coming from more posterior, I think we would have a good chance to implant a second device, but we will see. So we don't have the answer yet, but I think it's worth trying with one device in this position.
So maybe, Maria, we switch to the ICE probe. So we introduced here via the left femoral vein the ICE probe into the right atria, and now we need to get our home view, which I try to do.
Can we see
now. So just to explain to you who hasn't used ICE before, you see now here on the left-hand side a typical RV inflow. You see the Pascal device already positioned in the valve.
Can you see it in full view? Can you see everything in London? Question to you.
Yeah, it's cut a little bit on the left side.
It's cut a little bit. Maybe we can try to show it in full screen.
And Tanya, if you...
Is it better now?
Yeah,
Yes.
perfect. And if you could increase a little bit the loudness of Tanya's micro would be helpful.
Okay. So maybe you can hear me better now? I
Yes.
speak up a
Much
little
better.
bit?
Thanks.
Okay, perfect. So, so this is 0 degrees, where we just get our home view. And now to optimize the resolution of the ICE probe, we switch to 45 degrees because it's more posterior position.
So maybe, Tanya, perhaps what we can do is we let you work quietly if you want, and we continue with the program and we come back to you to see the results. Is that okay for you?
Yeah, for sure, no problem.
Thank you.
So we will proceed meanwhile because it needs a little bit of adaptation, Illing. So we would like to hear your perspective on the proceduralist view concerning new imaging modalities and structural interventions.
Thanks, Nina. So as a brief interlude, I'm just going to give a slightly different slant in terms of how we might think about incorporating 3D intracardiac echo into our workflows, focusing on tricuspid TEER, using the case Tanya has illustrated with us so far. So I've chosen to focus on just a few key elements, thinking about how our workflows and our team communication should look like, the procedural aspects that we should pay particular attention to, paying attention to safety, what this might do for our procedural durations, as well as hopefully influencing slightly more positive clinical outcomes. And then really just having a think from a heart team perspective, which patients and therefore case selection might benefit from this addition to our therapies. So if we think about workflows and communication, I think what we're seeing already that has started to be illustrated in the live case we've seen so far is the procedural planning and execution. I think the 3D intracardiac echo provides additional information, particularly in tricuspid TEER, where we encounter challenging imaging. We may not have the benefit of both clearly illustrative mid-esophageals and transgastric views, and particularly, certainly in sessions throughout the Congress, each of us have seen and shown cases and discussed cases where we may actually predominantly use one imaging plane, but actually why not have the additional benefit of clear leaflet visualization to improve leaflet capture, and therefore gives us more confidence in accurate device placement. I think the VeriSide Pro has very clear procedural workflows for us to try and optimize so that with the continuing dialogue from a proceduralist point of view and with our images intraprocedurally, we're actually better able to communicate when we might switch from one imaging modality to the other. One, just to really streamline, and the digital steering aspect, I think certainly makes it simpler from my perspective as a proceduralist, in terms of catheter stability, ensuring we actually have continuous image visualization during the procedure. All of us who do these procedures as a heart team know that really first and foremost for us, we emphasize the procedural safety of tricuspid TEER as a low-risk procedure. We know that some patients may be rendered ineligible from imaging grounds, and certainly on the left-hand side pie chart, it was interesting to see that really even across randomized trials, which are limited within the field, 10% of patients may be excluded from the therapy because of suboptimal or non-diagnostic transesophageal echo images. This means that there's certainly a tenth of our patients potentially, which may be underestimated, who may actually benefit from therapies by combining imaging modalities, including intracardiac echo. I think imaging confidence is important for us as a collaborative team. Certainly early in the experience curve of tricuspid TEER, we've all experienced single leaflet device attachments, largely due to perhaps challenges of visualizing the leaflet grasp, taking a leap of faith sometimes in hoping that we actually have achieved adequate leaflet capture. And SLDA rates that you can see on the bottom right-hand side across multiple studies have ranged between 6 to 9%, which is not insignificant as we continue to try and improve procedural outcomes in this patient population. And we know that real-world imaging, as we've seen in the live case, can sometimes take a little more adaptation than patience from us as a team in general. Finally, the aspect from a procedural point of view to think about is actually streamlining our workflows. Tricuspid TEER can be a variable beast. Some cases are nice, quick, easy, and predictable, but the vast majority of day-to-day tricuspid procedures may be not what you set out to anticipate in terms of procedural strategy. And we can see here across the 3 studies quoted that mean procedural times can certainly range from 1.5 to 2 hours, and therefore incorporating ICE may help to reduce procedural times. We've already heard from Victoria how it may lend itself to procedures under sedation rather than general anesthesia, which may be important in an increasingly frail multimorbid cohort. And so hopefully improving resource utilization for us as a team. In the final 2 minutes, I'd like to share with you our early experience with using the VeriSight Pro and how it helped in this particular case of an 86-year-old female with torrential tricuspid regurgitation. She's had a previous surgical perimount aortic valve replacement and mitral valve repair, so already heralding some potential imaging challenges in terms of shadowing and leaflet visualization. She has some other comorbidities that are important. She has some esophageal pathology, so for us to be mindful of potential increased bleeding risk in an octogenarian, perhaps with fragile esophageal tissue. She has NYHA class 2 to 3 exertional breathlessness and following heart team consensus, although she had also screened past for tricuspid valve replacement with Evoke. We felt that TEER was a little bit more complex, but actually lower risk for her. You'll see on her representative transesophageal echo images on the right-hand side, she has a broad, predominantly central jet of tricuspid regurgitation that quantitatively came up severe, even though I appreciate this may not look as much in the representative images I've shared. And on the transgastric views, she has quite a complex coaptation gap with tricuspid regurgitation oozing across her coaptation line. And so given the anticipated challenges, we felt ICE might lend us a helping hand. You can see on her left-hand image of her transesophageal, mid-esophageal views as we approach with a Pascal ACE device. Her views are all quite rotated on transesophageal imaging. The septal leaflet is visible. There is some restriction. And actually in this view, the coaptation gap looks a little bit more challenging. We obviously then switched to intracardiac imaging once we had navigated down to the valve with some baseline images just to show us where we should be targeting by combining both modalities. And then the transgastric view, we elected to start anteroseptally. We've had multiple discussions over the course of this meeting in terms of a zipper or clover approach. We initially thought we would take a zipper approach starting anteroseptally, and then using intracardiac echo on the right there just to line up our implant. Rather pleasingly, in the selected target deployment area between anterior and septal, we had good leaflet visualization, single grasp leaflet capture, and actually you can see on the right-hand image, quite an anterior position of the ACE implant with near obliteration of tricuspid regurgitation and an annuloplasty effect that we could confirm both on ICE with our transesophageal echo, So given the annuloplasty effect and the significant reduction in tricuspid regurgitation with a reduction in the right atrial pressure, we chose to accept this as our final result in this octogenarian. And for us, it was actually quite useful to see that the procedural time was 25 minutes from the insertion of the ICE catheter. And just to confirm that a post-procedural follow-up at 2 months, she still has trivial to mild tricuspid regurgitation with significant symptomatic improvement. So really, I hope I've been able to illustrate that team-based coordination and communication is as pivotal as it's always been in structural heart intervention, perhaps with an added layer of a different terminology to get used to with intracardiac echo. And it certainly helped us to provide added reinforcement during the critical steps of decision-making intraprocedurally, and I'm sure we'll see this continue to grow across a broad range of transcatheter intervention. Thank you.
Thank you very much, Eileen. I don't know if we can connect back again with the cath lab. If we have news, we will appreciate that, if that's possible, to bring them in.
Welcome back to the hybrid OR here in Bad Oeynhausen. Thank you so much for giving us some time to figure out the best position here. We were now able to grasp, with the help of the ICE catheter here, you can nicely see now the leaflet insertion, and also now here.
So we lost the connection. Can we do something concerning that?
We can still hear you, Nina.
Yeah, we can't see you, actually.
Oh,
yeah, now
it's
okay.
Perfect. Continue, please, Tanya.
Okay. So, have you seen the ICE images?
Yeah, perfect.
Okay, so now you see them on the right-hand side, the grasping view, and you can now nicely see that the lateral and also septal leaflet are nicely grasped in here. On the left-hand side, as explained before, the RV inflow. And maybe, Maria, you now go to 2D and we check the color. And I think here it's important, of course, that with the ICE catheter, this looks different from what we are used to by TOE, so we should not overestimate it here. Maria just adjusts it and give us a color.
Nice.
So, what do you think, Kai? I think it doesn't look too bad, I would say.
No. We can confirm this in maybe in TOE and in transgastric short axis to make sure that we have a good leaflet insertion. We already have the impression that it's a solid grasp, but we should confirm it in TOE.
Yeah, Kai and Tanya, but you gave us a really nice view of the ICE images, how good the quality can be, but it takes sometimes a while to really adjust everything perfectly. So we would like to see a confirmation, color Doppler, and then unfortunately we have to leave you because we have to continue with the program if this is fine for you.
Sure.
So I think this is confirmatory by TOE. You can also see that is no significant TR left here, the position as we intended it to be. So I think we would leave it like that.
Yeah.
Fantastic. So big applause.
Beautiful.
Tanya, Kai.
Beautiful.
Thank you.
So, and we are going to continue, Victoria, with your perspective as an imager.
Yes, so I will try to provide a perspective of the imager. Who knows me, I'm quite practical, so I also like to go into the cath lab with less toys as possible to make it clean and improve the communication. So this slide you already show. We tried always to use the most appropriate imaging modality that is going to help us in guiding the procedure, but sometimes you need two. What is important from the imager point of view is our position. I think that sometimes that is kind of forgotten. Probably for me, the most frequent one is not here, is much more in the other side with the fluoroscopy in this way. So I will be the opposite to the interventionalist because it's the way I have the communication, and I can see the fluoroscopy in another screen that they put for me, so that is more the useful one. But in the case of we are using ICE, this needs to be planned because the catheter may come from this direction, and then where do you put the machine is going to be a key for that, even though we can have very long wires in order to connect the machine from the distance. It's important also to be sure that it's going to be a reduction of the radiation that, as we can see in this publication, the interventional echocardiographer is the one that is receiving more radiation in procedures such as left atrial appendage closure or transcatheter H2H repair. So for me, what I want from an imaging modality when it comes into the cath lab is that our position is comfortable for working together, for having a good communication and receiving as less as possible radiation. So you have seen the image quality that we can get so far now with transesophageal echo, with ICE catheter. I think that fluoro is key for specific procedures, but sometimes you don't need the fluoro because you are looking at our echo images. Don't press the fluoro, please. Thank you.
Thank you, Victoria, and super nice in time. So we have time for another procedure with intracardiac echo. So Miriam, you will give us some aspects of intracardiac echo in left atrial appendage occlusion.
Thank you very much. A warm welcome from my side as well. The most important aspects have already been nicely pointed out, so I will just echo some of them. I'm happy to present to you the newest imaging data, which is a nice case from the University Hospital of Bern, so thank you to the colleagues there. They treated actually an 86-year-old female patient known for atrial fibrillation since many years, being on DOAC, but experiencing repeated GI bleeding under this therapy. So there was an indication for the occlusion of the LAA. And what is key to a successful procedure is a standardized protocol. And this is not only applicable to all structural procedures themselves, but also to the integration of imaging. It is crucial to have this protocol, and then you can make the most benefit out of the imaging using TOE or ICE. This is the proposed imaging protocol for the use of intracardiac echo in the procedure of LAA closure. So let's just quickly go through them together. So you see that already the transeptal puncture can be guided nicely by the ICE probe, making the LAA occlusion a possible standalone procedure for the application of ICE. And what is important, because it hasn't been mentioned yet, we can advance the ICE probe from the right atrium to the left side to even increase the imaging quality and to be in direct anatomical proximity to the structures on the left side. So what you actually do is, after the transeptal puncture that you do from the right groin, you retract the sheath again over the septum, keeping the wire in place in the left atrium, and then over the left groin, you have the ICE probe, which you can then nicely adjust by echo and fluoroscopic control. Of course, not too much fluoroscopic control. Victoria, message well received. And then you can just follow the wire actually over the septum in the same puncture. And then you can again advance the sheath if needed, and otherwise you can then follow with your delivery catheter. And then you have your ICE probe on the left atrial side, and you can get like a full sweep of the LAA actually remaining in one position. When after passing the septum, you just retroflex the ICE probe, which gives you actually a nice view directly in the direction of the LAA. And being at 0 degrees, briefly being the TOE view of 90 degrees, you have the LAA and the mitral valve in your plane. And what you can then do is you can turn the probe directly, or your colleague standing at the machine can actually just do digital angulation. So you don't even have to move the probe after crossing to the left atrial side. So you can adjust the angulation to minus 45 degrees to see the LAA and the aortic valve. And you can turn in the other direction, the digital angulation, to be at plus 45. And you already see the corresponding degrees for TOE to have this LAA pulmonary view. And by that, you can really appreciate the full anatomy in all the complexity of the LAA. And so in this case, this is the MPR by ICE. So you can easily see all the different dimensions. You have the 3D in the bottom right image. And then you can perform the measurements that are necessary for the device that you want to use. In this case, it was a Watchman device, so the measurement of the parameter to define device size. And after that, following the standardized procedural protocol, you add the fluoroscopic angiography for additional measurements. Maybe you have additive measurements from a pre-procedural CT scan, and you define your device size. You implant the device. You don't have to move the ICE probe at all. You can easily use the same position, looking at the LAA, having it centralized, and getting a nice X-plane image using color Doppler or not. And then you just apply, as usual in your standardized protocol, the pass criteria. So you control for position of the device, this being, of course, specific, using one or the other. You do the anchoring, the tuck test. You look for device size, compression. Again, you can do all these measurements from the same position. You don't have to change anything. And of course, also controlling the seal and possible prostatic leakage. And then device result after the release. And I think you could see nicely that for LAA closure, a little bit in contrast maybe to IV valve interventions, this can really be a standalone application for the use of ICE. And you can do 2D imaging for most of the time, but 3D adds a lot of details, especially when it comes to the initial anatomical comprehension of the LAA that you're dealing with in the procedure. So ICE can facilitate LAA occlusion procedures as a standalone imaging technique, and 3D allows for more comprehensive imaging at every step of the way. And you don't have to manipulate the probe at all, but it always has to be on the basis of a standardized LAAO protocol. And of course, the close communication still remains the key to a successful procedure. Thank you.
Thank you very much, Miriam. Becky, you are most likely the person in the room who has the most experience with both of the imaging modalities we've seen today. So I would like, we don't have much time for discussion, but I would like you to give us a perspective. So in which scenarios is ICE an imaging modality we would use, and how does it drive further on the procedures? And on the other hand, some comments also on the device guide from your side.
Yeah, so we're using ICE alone for LAA occlusion in maybe 25-30% of our cases, ICE only, no TEE. And the issue there for me is that we always want to reduce PDL, peri-device leak. And so because of what we discussed before, which is that we have a short axis to the probe, we now have to figure out a way to utilize the long axis only in order to scan across the surface of the probe with color Doppler. And that's what this probe allows us to do. Just like a TEE probe, you can elect to have your orthogonal view be a lateral plane orthogonal or an elevational plane orthogonal. So we're using the elevational plane, lining ourselves up, and then scanning across using elevational plane. And that allows us to maintain using all your crystals along your piezoelectric elements along the long axis of the probe at all times to do the scanning. And that's worked for us really, really well. There are some patients that it's safer not to intubate. They're very sick, they've got COPD, whatever. There's a lot of these patients out there, and the LAAs in particular, you can do as standalone. The tricuspids, we've not done it very often on mitral side as adjunctive imaging for both the tricuspid mitral. We usually use it as an adjunctive imaging, but about 25% of our tricuspids we're using ICE as an adjunct to as you just saw, to the tricuspid clip, and we've used it maybe 3 or 4 times even for an evoke when our imaging is truly limited. And I think it's really helped with procedural confidence, as well as accuracy of positioning and making sure that you've optimized the grasping of the leaflets, because you can always optimize, individual optimization. And so the ICE has really helped us, I think, get an optimal result, because we're really shooting for mild tricuspid regurgitation. As you saw, they got to trace. I mean, it was just a beautiful result.
So perhaps one question before we close. So are the projections at the degrees as the same and the TOE, I guess, for a tricuspid valve intervention? Because there is a doubt that perhaps there is the same shadowing if we reproduce exactly the same flow and outflow view.
Yeah, but you see where the probe is, right? Because it's on fluoro. You could see it really well on the fluoro. Yeah. And then on the ICE imaging that you showed, you could see it very well with it retroflexed. We use 3 different views for the left atrial appendage, depending on how good the imaging is. We obviously love the retroflex if you can. It gives you a slightly further field, which means gives you a wider sector. But we'll also use the pulmonary vein. We'll also do an inverted mitral valve view in order to really optimize the imaging of your device. So they're not the same imaging planes at all, and you just have to learn what they are.
Perfect. So Nina.
Yeah, thank you so much. Unfortunately, we have to close the session. So what did I take home for today? So the use of 3D imaging modalities, it's for precision. And we need maybe a combination of 3D TE, 3D ICE, and DeviceGuide. But these imaging modalities may enhance accuracy, you just pointed it out, Becky, and the confidence during the procedures. The roles need be clearly defined, and this is something Eiling and Victoria discussed. It's a strong teamwork, and it improves safety and efficiency if you have a good communication in between the imaging person and the interventionalist. And we've also seen, most likely from your presentation, Miriam, that a streamlined workflow and smart integration of imaging modalities reduces anesthesia and procedure time. And for example, with intracardiac echo as a standalone, we can go or come to a minimalistic approach and get to, it's needed in current times that we come to a faster turnover of our patients in the cath lab, because cath lab time is something which is valuable and it's needed. So streamlined workflows will be needed in the future. So thank you so much for your attention. Thank you so much for being here as panelists, as female panelists, and enjoy the rest of the conference.